for any other purposes. If you, for any reason, do not want to participate in a recorded event, please feel free to leave at this point. However, your remaining with us implies your permission to be part of this educational activity. Next slide, please. This program this evening provides 1.5 hours of physician Category 1 AMA continuing medical education credit. Sovah Health designates this for that amount. We are a member of the Southern States CME Collaborative, which includes the Medical Society of Virginia, Medical Society of North Carolina, and that of Mississippi. In addition, this program provides 1.5 hours of nursing CE credit provided through the Virginia Nurses Association. Sovah Health participates with the Nurses Association as an accredited provider. Next slide, please. The program was developed to promote several desirable physician attributes, including our providing patient-centered care, employing evidence-based medicine in practice, and expanding one's medical knowledge. Next slide. Dr. Wolf, who's our second speaker, reported 2 commercial relationships in Vivid. He's a consultant for and for Janssen. He's an advisor on drug safety. Dr. Wolf has agreed to mitigate those relationships by submitting his slides for CME review, which he did before the program, and they're without any commercial bias, and then attesting that any of the clinical recommendations that he will be making will be evidence-based and free of any commercial bias coming from peer-reviewed literature and adhering to evidence-based medicine practice guidelines. Next slide. Dr. Barada, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships. There is no commercial support for this educational activity this evening. It is supported by, next slide, the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. This fund was created by Dr. Landis upon his retirement a number of years ago from the urologic clinic, which he founded, and it's allowed for a unique endowment for medical education programs, not only for physicians, but for all forms of allied healthcare professionals within our, if you will, Dan River region community. This evening, probably, or in the first thing in the morning, you'll receive by email a CME evaluation form. It contains some 7 questions and some other information. It will ask you to re-enter your name and email address. That allows us to send you a CME participation certificate. Please, therefore, use your full real name when you fill out the eval form demographic information. No nicknames or short names or cute names, please. If someone else is logged on with you to watch and listen to the program this evening, which is fine to do, be sure and let Mary Kent know that so we can be sure they receive credit for their participation. An eval form is not required for us to send you a CME certificate. If you prefer not to do an eval form, please let myself or Mary know about that, and we'll make sure the certificate gets to you. I'll call to your attention question 4 on the eval form, which is what changes do you plan to make in your practice as a result of this program this evening? And that is for everyone, not just the physicians. And we all practice our healthcare skills within our scope of practice. So tell us what you may be changing from what you learned this evening. Next slide, Mary. Next slide, please.
I'm trying. Somebody else took control.
Oh.
Okay, let me see. Wow.
I can tell you what the next slide tells you. As you, if you can try to get that so we can share with them the upcoming programs.
I'm working on it.
What the next slide shows is that for the residents on the call, your coordinator, that's Dara Johnson or Lori Galvez, track your CME participation so you do not have to keep up with the certificates you'll be receiving from us. For the other physicians on the call, please know that we participate in the ACCME PARS website passport program, and so we will report your participation to ACCME passport, and it will be there for you if you need a record of your attendance. In order for us to do that, you're asked to, next slide, to one
Right.
time basically provide to us your name and birth date, month, and year, but not the date. And in fact, the state in which you're licensed, and we will put that on the website for you that you participated. Basically, if you've done that once, you don't have to do it again. And there is information on the about sheet about that. Next slide, please. Questions are encouraged. Both Dr. Barada and Dr. Wolf, who you're going to really enjoy listening to this evening, are very user-friendly. And if you have a question, please send it through the chat, or at the time when they ask for questions, just speak up. Once you've asked a question, we ask that you mute your microphone so that we don't get feedback. You're more than welcome to ask more than one question. In fact, we urge you to, and your comments are welcome as well. Next slide. We want to show you the couple of upcoming programs. Next slide. In 2 weeks, we will have a Thursday evening, 7 p.m. program similar to this evening that will focus on women's cardiovascular health, and specifically the management of coronary heart disease that is often presenting in an asymptomatic way in women. We have two great speakers, Dr. Shah, one of the cardiologists from Duke, who will talk about risk factors in general and screening of cardiovascular risk factors for women. And then Dr. Hashim, who is at Georgetown University in Washington, and he's going to talk about the challenges of evaluating women for active coronary heart disease. Oftentimes, stress tests are not reliable to exclude coronary heart disease. A lot of times, coronary angiograms are thought not to show significant lesions, while MRI angiograms and other techniques can really show powerful, potentially lethal lesions that can be fixed in many, many female patients who have coronary heart disease that presents in atypical ways. Next slide. And then in October, we'll have actually two programs. The first one is the only one I'll highlight for you this evening, and that's on Thursday, October 10th. We will do our annual oncology update, and this year it's on recognizing and managing melanoma. Dr. Quantra, who's one of our radiation oncologists, will chair and manage that program. It'll have two speakers, Dr. Shah from Duke Health, who will talk about the medical oncology management of melanoma, and then Dr. Paul Mosca, who's a general surgeon and surgical oncologist at Duke, about the surgical management, staging, and so forth. I hope you'll be able to attend those. Again, those are two really good communicators. Next slide, Gary. So this evening, it's my delight to introduce Dr. Barada to you. Dr. Barada is from UNC Chapel Hill, where he is the founder and co-director of the COVID Recovery Clinic. He had his training largely at Wake Forest and then UNC. He did his undergraduate work in biology with a minor in chemistry, graduating cum laude from Wake Forest University as an undergraduate. He stayed on there to receive his doctorate of medicine and MBA in a combined program at Wake Forest, or what used to be known back in my day as the Bowman Gray School of Medicine. In that setting, he had two major awards. He was chosen for Alpha Omega Alpha, which is the honor society among medical students, and he received two business school awards, including a unique reward for him developing a pay-for-performance business model that was not only recognized as outstanding, but was implemented within the internal medicine clinic at Wake Forest. Following that, he did his residencies at UNC Chapel Hill in physical medicine and rehabilitative medicine. There, he was chosen as a resident of the year, as a resident, and continued to be a real star in his chosen profession. He's obviously board certified in physical medicine and rehabilitation. He's had both external and internal recognition of his excellence in patient care and academic efforts, having been listed for several years as among the so-called top doctors by Business Weekly in North Carolina. He's had numerous publications and in peer-reviewed journals. He's authored 4 book chapters, and he's a reviewer for the New England Journal of Medicine and the British Medical Journal. It's a delight to have him with us tonight. So, Dr. Barana, if you'll bring your slides off, you'll probably knock Mary off. And we thank you so much for doing this.
You're muted, Dr. Barada. Just so you know.
Thank you. Can you hear me now?
Yes, yes.
Thank you so much for the kind introduction. And can you see my slides as well?
Yes, we can. They look great.
Okay, one last question. Can you see this laser pointer?
Yes.
Okay, perfect. Well, that's all great. Nice to see you all this evening, and thank you so much, Dr. Moore, for the kind introduction and the opportunity to speak to the group. So I am a physiatrist, a specialist in physical medicine and rehabilitation, as Dr. Moore had mentioned. And over the last 3.5 years, our Department of PM&R at UNC has operated a long COVID clinic called the COVID Recovery Clinic. And I look forward to sharing with you some, I think, very pertinent information about the condition, the understanding of which has changed over the recent years, as well as some up-to-date diagnosis and management techniques. So here's the agenda for my talk this evening. I will first provide some updates about what long COVID is in 2024, because that looked different than what it was in 23 and 22. The epidemiology and impacts of long COVID, potential mechanisms of the syndrome, management of some of the most common symptoms, and then how do we manage long COVID in a post-pandemic world. So we'll start with long COVID in 2024, and the reason why I wanted to highlight this, I wanted to use this term in the section is because there have been differences in the definitions of long COVID over the years, and this has led to some challenge in really making diagnoses for individual patients at times. And it's also resulted in challenges with engaging in research, because if an individual patient, if you were to ask multiple medical providers, some may feel that the person might have long COVID, others maybe not. And then that makes aggregating their particular situation or response to medicine in a research study particularly challenging. So earlier this year, the National Academy of Science, Engineering, and Medicine authored a collaborative long COVID definition, and this was put together by a committee of experts throughout the country across a number of specialties. This is, I would suggest, the preferred definition for long COVID at this point in 2024. I'll give you a little example of the differences. Previously, CDC was defining long COVID as persisting symptoms lasting more than 4 weeks, whereas other large health organizations here in the US and elsewhere were using a 3-month timeline. So I think the most accepted consensus definition is this one at this point, and now this has been adopted by CDC. And it states that long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. So you can see that there are a few different key parts to this definition, and this is a high-level definition. The consensus definition also digs down a little bit deeper, and I'm not going to read all of this, but I want you to be aware that it's out there, and there's actually a whole book that's published on the consensus available at nationalacademies.org. The other important parts to this consensus definition, which are accurate in my opinion, include that long COVID can manifest in multiple ways. And there are many different types of signs, symptoms, and individual diagnosable conditions that would fall under long COVID. Some patients will have single or multiple symptoms, including things like fatigue, concentration or memory difficulties, fast heart rate. And some patients will have single or multiple diagnosable conditions. And these might include things like lung disease, mood disorders, POTS, which is postural orthostatic tachycardia syndrome, and also myalgic encephalomyelitis, chronic fatigue syndrome, which I will touch on later in my presentation. So there are some important features of long COVID. This is also from the consensus definition. And these include that long COVID can follow asymptomatic, mild, or severe SARS-CoV-2 infection. And this could be a diagnosed and recognized prior infection or not. Long COVID can be continuous from the time of the acute illness, or there can be somewhat of a delayed onset for up to a few weeks or months in what had appeared to be a full recovery. Long COVID can affect children and adults regardless of their health, disability, socioeconomic status, and other demographics. Long COVID can exacerbate pre-existing health conditions or present as a new condition. Long COVID symptoms can range from mild to severe, and they can resolve over a period of months or they can persist for years. Long COVID can be diagnosed on clinical grounds. No biomarker currently available demonstrates conclusively the presence of long COVID or can rule it out. And long COVID can impair individuals' ability to function. And this includes in the school setting, in the home setting, and also work. So some patients will have a really substantial physical and emotional impact. All right, so now that we got that big definition out of the way, which I think is really worth reviewing since it's so complex, I want to share some other aspects to be aware of. This figure on the left is from 2021. This is one of the first reports, meta-analysis of different symptoms after COVID. And you can see dozens listed here. And in more recent medical literature, there have been over 200 symptoms that have been identified and reported to be related to prior COVID illness. On the right side, you'll see different lines here with on the axes, symptom burden on the vertical and time or duration on the horizontal. And what we're trying to illustrate here is that there can be different trajectories of symptoms for patients. Some people, like in this Carolina blue line, will have a strong, like a high symptom burden initially during the acute phase, and then during the post-acute phase, there may be a waning of the symptoms, but still present. The purple line has kind of a fluctuating and episodic course. And the dark blue line is also an episodic course, but accelerating or worsening symptom burden. Okay, so let's move into the epidemiology of the condition and also some impacts. Long COVID is unfortunately very prevalent still. We are now in this post-pandemic world with COVID being endemic. We hear a lot less about COVID, acute COVID now, even though despite there has been this recent uptick of cases in the last couple months. But long COVID really still is impacting many people in our communities, our states, and nationally. The CDC operates a household survey called Household Pulse, which at present surveys about 60,000 households monthly. This is nationwide. And as of July of this year, the most recent survey period, 18% of US adults responded that they feel like they've had long COVID. And 5% of the US adult respondents report that they currently have long COVID. And this is not just a couple of figures in isolation. Looking back through the data, both available through CDC and other resources, these numbers are consistent. These are really substantial percentages when we think about the overall population. And so if you were to kind of extrapolate that, that 5% of US adult respondents feeling that they currently have long COVID, multiply that by 258 million US adults, this means that there could be about 13 million adults living in our country who currently are experiencing post-COVID issues. And these can be widely variable. We'll talk about some of the symptoms here shortly, but the scale of this syndrome should not be understated. So I mentioned that I operate the UNC COVID Recovery Clinic, and over the past 3.5 years, we've seen about 3,200 patients with long COVID, mostly from North Carolina, but many from surrounding states and regionally, and some have traveled great distance to come to us. We actually have seen many dozen patients from Virginia and especially Southern Virginia. We are doing a study of patients in our clinic. This study is called Impact Long COVID, where we're trying to gauge the how the condition is affecting our patients. And you can see here that the vast majority of patients in our clinic describe feeling fatigue or tiredness, over 90%. This is far and away the most prominent post-COVID symptom. Brain fog or cognitive issues fall in line second. And then there are a variety of other problems you can see listed here, including sleep disturbance, shortness of breath, aches and pains, mood changes, and headaches. And down here, you'll see that this is pretty sobering the data, but definitely consistent with what we're seeing in our clinic. 69% of people in our clinic report a reduction in their work hours due to long COVID symptoms. 33% report ever going into debt due to their long COVID symptoms. 85% report difficulty participating in social events due to their symptoms, and 54% report difficulty with caring for dependents, like childcare, providing childcare. So, the effects for these individuals, at least the ones who are being referred to our clinic, which admittedly is going to be a more complex, more affected sample, these patients are really impacted. There are vocational impacts, as you can imagine, as well. And this data from Kaiser Family Foundation shows on the left side, this is the breakdown of all adults in 2019, with the light blue being fully employed, and then reduced hours below that, and out of work below at 7%. People who identified with long COVID, and this data is a little bit old, it's from 2022. People who identified having long COVID who were working prior to their infection had a substantial reduction in their work abilities, with less than half still being fully employed when they were experiencing long COVID, and close to a third having reduced hours, a quarter being out of work. Long COVID can be a disability, but it is not necessarily a disability for individual patients. In July 2021, the Biden administration announced that long COVID could be a disability under various federal civil rights laws and the Americans with Disabilities Act. So there are certain provisions within the ADA which describe that if a condition substantially limits one or more major life activities, then a condition, long COVID included, can be considered a disability. So a person with long COVID has a disability if their condition substantially limits one of these major life activities. I've listed some examples of major life activities, and this is pulled from HHS, Health and Human Services website. Major life activities can include a wide range of things, including performing manual tasks, seeing, hearing, eating, walking, standing, lifting, learning, concentrating, communicating, etc. And it can also, if there's impairment of a bodily function, such as certain proper function of body systems, then that could be considered a disabling condition too. I want to share this because I had shown you in the past few slides about the substantial vocational or work-related impacts to long COVID. Many people that come to our clinic are needing some support from their medical provider to substantiate the need to remain out of work for a certain period of time. And I want to echo or emphasize that it can be very helpful for a patient's recovery to work with them to get them the time that they need so they can focus not on their employed job, but their recovery. So that can be their job while they're taking leave from work. Okay, I'd like to move into potential mechanisms, and even still at this time, there is not a full understanding, but there have been some advancements in the potential mechanisms which may be underpinning the condition. I like this diagram, which I pulled from a journal article, and I think it's interesting because you can see the clustering of symptoms that goes on with this condition, and the circles in this figure, the outer circles in gray, show different individual symptoms that this particular study was assessing. The colored circles closer to the center are the clusters that these were deemed to be within. And you can see that, again, fatigue is the top cluster. It's the biggest circle here. Neurocognitive impairment, or you could call it brain fog, the second one. And then moving downward, there are chest symptoms, mood symptoms, pain, etc. And so how could one disease cause such varied effects? We are seeing and learning that long COVID can pretty much affect most any part of the body and the brain too. And how does this happen? We are also seeing overlapping sequelae. So long COVID, also called PASC, which is post-acute sequelae of COVID, has these overlapping syndromes, including some that cause exertional intolerance, such as chronic fatigue syndrome, some that cause cognitive disorders, brain fog, some that cause dysautonomia, and so we're seeing a lot of tachycardia with palpitations, POTS as well, and then some syndromes with pain. So how does it cause all this? Well, long COVID is a complex and multifactorial condition that's going on in the body. Just like acute COVID can cause many different symptoms in an individual, long COVID causes different effects, whether that be symptoms or identifiable diagnosable conditions, because it is challenging the body in different ways. Some of the key manners by which this may happen include immune dysregulation, where there is an abnormal immune response, probably a revved up immune response causing systemic inflammation. Also, there is the potential for persisting virus or viral fragments that are contributing to symptoms. There is a recent recognition that gut dysbiosis can affect individuals not only in the GI tract but throughout the body, with recent discussion of the gut-brain axis, where the altered GI flora may contribute to substantial changes throughout the body and brain. There's the concept of autoimmunity, which I believe is present in some individuals, although this is probably to a lesser degree than some of the other mechanisms. And there are some suggestions of endothelial damage. Of course, we know that to be the case for many people with acute COVID, but there are also blood clotting disorders given the prothrombotic and hyperinflammatory nature of acute COVID. There's also dysfunctional neurologic signaling, and I'm going to touch on some neurologic changes in just a moment. So I wanted to share with you some primary literature to support these potential mechanisms. This is not a deep dive or comprehensive, but just to give you some examples of what has been seen. This study in gastroenterology showed that there can be persistence of viral antigen for 7 months in the GI tract. You can see in the left panel here, these are whole SARS-CoV-2 particles, whole virus in the acute illness. And in the post-acute illness, the diagram shows more like fragments. But these have antigen and can be stimulating to the immune system, leading to inflammation and then likely leading to some of these symptoms. From a neurologic perspective, there have been some studies which have demonstrated increased blood-brain barrier permeability, potentially related to damaged endothelium. And I also had mentioned about the prothrombotic nature of COVID. There is well-known cytokine storming that goes on, and this could lead to some changes to microglia and other CNS cells, leading essentially to excitotoxicity and then going into neuropsychiatric symptoms. There's also been some evidence of fibrin particles forming, and so these are termed in some circles microclots, even though they're not full clots. They're more microparticles. And the idea here is that this persistent fibrin, which is not present in healthy blood plasma of individuals who have recovered, but is present in individuals with long COVID, these fibrin particles seem to have a hyperinflammatory effect themselves and are tough for the body to break down. Here are some additional recent findings of importance. From a neurologic perspective, a study published in Cell last year shows that people with long COVID have reduced serotonin. And this may be in part related to changes in the gut. And I was just sharing with you about dysbiosis, but the serotonin precursors seem to be present in a lower amount, leading to less serotonin. Also, individuals with long COVID have been shown to have lower cortisol levels. And there are many other changes that are being identified between people who have recovered from COVID and those who continue to struggle. All right, so let's move into management of the common symptoms. And these are hopefully what I can share here are some techniques that you may be able to utilize in your clinical practice if you're seeing patients. First of all, I want you to know that chronic fatiguing illness is not new. Long COVID is not the first infection-associated chronic illness. Historical descriptions date to the 1750s with this condition called febricula, which was described to include fatigue, neurologic and psychological elements, and low-grade fever. This has been followed by a number of other conditions which are listed here, many of which have resemblance to one another and also resemblance to long COVID. I've shared with you that fatigue is one of the most common symptoms that we experience, that we treat in the long COVID clinic, and it can be one of the most challenging to manage. We try to have a holistic approach to our patient care and think about other causes of the patient's symptoms, and I imagine you do in your practice too. So when seeing someone with fatigue, I think it's important to assess not only the long COVID fatigue, but other aspects, including how are they sleeping? How's their mood? Respiratory or cardiac concerns as well. We ask about post-exertional malaise in our practice, and this is a fatigue pattern which is common in long COVID and a key part of ME/CFS. And I'm going to touch on PEM on the next slide. We do a basic lab workup if it's not recently been done, just to rule out some other potential causes of fatigue. So we do CBC, CMP, some basic vitamin levels, ferritin and thyroid. Almost without exception, the labs are normal, except maybe low vitamin D, as is seen so commonly. We almost always have a normal basic lab workup. So here is some information on post-exertional malaise, and the image you see here is a roller coaster, obviously, and we call this the COVID coaster because there are these ups and downs with symptoms, and this is kind of characteristic for post-exertional malaise, and also another related condition called post-exertional symptom exacerbation. So it's the same concept, but more than just the malaise or the fatigue worsening. PEM is a type of fatigue frequently seen in long haulers, and it is characterized by severe worsening of symptoms after relatively light physical, cognitive, or emotional exertion. And we hear people describe things like, after I'm unloading the dishwasher, I feel knocked out for the rest of the day. I can't get off the couch. This is a roller coaster, though, for patients because there are some better times and some worse times. So the worst times are frequently called crashes. And during these crashes, which can be extended for days or even weeks in some more severe cases, during the crashes, not only the fatigue is worsened, but many aspects of the condition can be. It's important to know about PEM and whether it's present in your patient because this is associated with symptom worsening when a person overexerts. So if you're telling, if a patient is going and doing like a lot of activity at the gym, that can worsen the condition. So we avoid graded increases to activity. We counsel patients on energy conservation strategies, the 4 Ps. And fatigue management involves finding a good balance of these along with the energy available for a person's body. So we don't want them to overexert. The 4 Ps here, planning, prioritizing, pacing, and positioning, can be helpful to reduce the energy expenditure and find a better energy balance. We talk about some concepts. A lot of people, relate to money, and so we talk about energy as a budget almost, where investing building up this energy reserve and budget includes having good quality sleep, nutritious food, getting rest breaks for yourself. And expenses out of that budget can include physical, cognitive, social, and emotional activities. Now, that's pretty much everything that we do throughout the day if we're engaging in life. These are all potential stressors, and I counsel patients not to withdraw completely, but to try to find the balance to where they're not overdoing it and causing themselves to crash over and over and over. Because when they do crash on a recurrent basis, that slows their recovery. For managing fatigue, after we talk about the 4 Ps and treat underlying causes, we oftentimes work with our rehabilitation therapists, PT and OT, to provide a very gradual program for increasing activity, with the goal, again, of not overexerting. We talk about coping strategies, including identifying times of the day when they can be most productive, identifying work accommodations, and giving support from the provider level to have that. And looking at their medicines too, deprescribing sedating meds, and also considering meds to promote wakefulness or alertness. We use stimulating antidepressants a lot, like bupropion and fluoxetine. We're using a lot of low-dose naltrexone, which I'm going to share a little bit more with you on the next slide. Typically dosed between 1.5 to 4.5 milligrams nightly. And we are using stimulants as well, and these are pretty, these can be potent and pretty beneficial for more substantial fatigue. Things like modafinil and armodafinil are best for fatigue. Now, naltrexone is an opioid receptor antagonist, and at low dose, it's believed to work somewhat differently than in the full dose. At low dose, the medicine, low-dose naltrexone, is thought to have an anti-inflammatory mechanism, working as a toll-like receptor antagonist and also promoting or increasing endorphins favorable to the immune system. ME/CFS is a condition which overlaps with long COVID fatigue. And this is a condition which might affect up to a couple million Americans, often thought to be a sequelae of infectious illness. And so when patients come in with long COVID fatigue and meet criteria for ME/CFS, we make the diagnosis as well. Not that it dramatically changes the treatment approaches, but it can be helpful to substantiate their request for accommodations, particularly with work and also sometimes disability. ME/CFS diagnostic criteria include not being able to participate in routine activities that were possible before they became ill, lasting at least 6 months. They would have post-exertional malaise, unrefreshing sleep, and also some impaired cognition or orthostatic intolerance. So symptoms that occur more prominently when they're upright. The second most common symptom that we see is post-COVID cognitive concerns, commonly called brain fog, and this is characterized by poor memory and attention. If you did like a regular screening questionnaire, like a MOCA, patients may do fine on that. But in real life, when they are being presented with multitasking and a lot of distractions or noises, patients can become easily overwhelmed, and that's when the brain fog sets in. This is probably occurring because of a neuroinflammatory mechanism. And that being said, sleep or mood disturbances can contribute. Consider neuropsychological testing for your patients to get some objective information about how their cognition is, especially if there are school or work impacts. We use speech therapy as a cornerstone treatment for our patients with brain fog. speech therapy offers cognitive rehabilitation, kind of similar to what might be offered for a person with post-stroke or post-brain injury cognitive difficulties. And these strategies can be helpful for people with long COVID brain fog as well. We treat with some medicines as well. Bupropion can be helpful for improving focus. Guanfacine and N-acetylcysteine can be helpful to also improve focus. Low-dose naltrexone, some patients have described as clearing the fog for them. And then we will use stimulants as well, but because of their controlled nature, potentially dependency forming, it's definitely not our first line. I wanted to share, assuming that you'll get the slides set, wanted to share this paper, which is a pilot study on the use of guanfacine for people with post-COVID brain fog. Guanfacine is used primarily in the adolescent populations for ADHD, and it has some beneficial, some cognitive benefits in this population as well. So some advice for the patient with brain fog. These are strategies that are given to them with speech therapy, but basically balancing activity with rest, setting alarms or writing notes for reminders, using colorful paper and ink to catch attention, and making lists or check boxes to cross off tasks when they're completed. Shortness of breath is common, but actually becoming less frequent in patients as we go on. The first wave of patients that came to our clinic had shortness of breath as a very prominent symptom, but it's becoming less so now, probably because of the change to the virus with more of an upper respiratory predominant presentation. But for someone with dyspnea, it would be prudent to do a basic, like a standard workup, including checking an O2 sat, chest x-ray, D-dimer, considering cardiac causes. We recommend PFTs with DLCO. DLCO has been shown to be low in many people after COVID. We use chest x-ray as an initial screening. And you'll see the process here that you can use to proceed with workup. Getting a CT chest for abnormal chest X-ray screens, and then otherwise checking labs or PFTs to do the initial additional investigation. If the tests are normal, which they usually are, it's just helpful to validate the patient's experience and tell them that many other people with post-COVID issues have dyspnea. People with long COVID have been shown to have disordered breathing, and we have found benefit with breathing exercises called breath work. There are there are a number of online resources to give guidance on breath work, including at Hopkins and this website called Stasis. Okay, so kind of to wrap up and give the final pearls here. Anyone who gets COVID is unfortunately at risk for long COVID. People who have medical comorbidities, those who had the earliest strains, and females are unfortunately at higher risk. The good news is that Omicron is less likely to cause long COVID, but it does still occur with Omicron. And the more times that an individual gets COVID, the higher their cumulative risk for developing long COVID symptoms. There is benefit to using Paxlovid during the acute illness, and so there is a 26% risk reduction for post-COVID fatigue and cognitive symptoms. For many people, there is a gradual reduction of symptoms over time, but this is over months, and for some people, years. the symptoms for many people do improve, but they may not resolve. And the recovery trajectory can be quite variable depending on the underlying pathophysiology, which is really tough to determine, if not impossible in most cases. More straightforward symptoms like headaches may have a more complete recovery, but others like ME/CFS would have this episodic worsening and a less complete recovery. Staying up to date with vaccinations is protective, and this study published in BMJ shows that the more vaccines an individual has, the better protection they have against getting long COVID. And so I would definitely continue to encourage ongoing vaccination, and we'll hear from our next presenter on that as well. There are a number of clinical guidelines or guidance statements that are available at this point, including some through the CDC, and then also my national organization called AAPMNR has developed a number of symptom-focused guidance statements. In the coming, I guess, in the next few months, hopefully in the fall, we will have an additional publication on basically a compendium or compilation of the most important recommendations across these guidance statements. And I'm glad to share that with Dr. Moore if that would be helpful. And I'll just share with you maybe just one case here to give you an example of someone that we might see. A 38-year-old female with a past medical history of asthma presenting with persisting fatigue. Started following COVID illness 9 months before, and she describes feeling exhausted. She's having difficulty getting through the workday and having poor performance at work. She has some good days followed by some bad days. This is the episodic nature, the roller coaster. Sometimes she's unable to get out of bed due to fatigue, and she's had to withdraw from some of her usual household duties, including childcare, sleeping 9 to 10 hours a night, and waking unrefreshed despite that. The lab workup, as is typically, was all normal. We would refer her to PT or an OT who's knowledgeable about post-COVID conditions and can do a very slow rehabilitation process, being cautious of this post-exertional malaise or symptom crashing. We would encourage the 4 Ps, these energy conservation techniques, as well as activity and symptom tracking to identify triggers. And we would encourage her to just titrate activity very slowly. On follow-up several months later, she was demonstrating significant improvement to her symptoms, particularly when she follows the recommended plan, although there's not resolution of the symptoms. And out of the interest of time, I'll skip the second case. So in summary, long COVID is a wide-ranging syndrome which occurs at least 3 months after COVID. It is common, and 5% of US adults report currently having long COVID. There's a wide and variable constellation of symptoms. Medical providers can treat patients mostly by symptomatic management at this time, but there are some developing mechanistic treatments as well. Standard and novel rehabilitation approaches are hopeful, and there are benefits from being up to date with vaccination and also using antiviral in the case of infection. We at UNC are glad to see patients if you need additional help with people who you suspect have long COVID. We see patients either virtually or in person, although even if they're virtual, they have to be within state boundaries of North Carolina. We see adults and people who are having persisting issues more than 1 month after COVID illness. Our contact information is here for the referral packet. So that's the end of my presentation. It's been a pleasure speaking with you all this evening. Thanks so much for your attention. I appreciate it.
Thanks, Dr. Barada. Do we have questions for Dr. Barada?
Yeah, it's Dr. Miller.
Please, Gary, go ahead.
Yeah, probably anecdotal, but I've seen several cases of people who had what I felt was long COVID months after they had the COVID and then got their vaccine. They seem to get better. You know, the smell and taste problems went away in the brain fog. Is that just happenstance, anecdotal, or is there something to it?
Yeah, there may very well be something to it. I don't know of I don't know of studies specific to that vaccination as a therapeutic option after COVID to treat long COVID. I've heard similar anecdotes from some patients, but definitely not all patients. Not enough for me to make that as a general recommendation, but I think that could speak to some of the potential persisting viral fragments or viral load that is contributing. One of the key NIH RECOVER studies, and RECOVER is the long COVID research project. One of their key studies is investigating the use of Paxlovid for treatment of long COVID symptoms, and results from that will be out hopefully early next year. The mechanisms are still not totally known, but happy for those patients who had benefit.
Thank you.
Dr. Barada, there's a question in the chat. I don't know if you can see that now, if you want to just glance at it, or if you want me to read it to you.
The
About documentation.
Is there documentation of the incidence of autoimmune thyroiditis specifically increased after COVID-19 infection? And do we routinely test thyroid autoantibodies? We do not routinely test the thyroid autoantibodies unless there is other reason to. We do in our basic labs check a thyroid panel, though, a thyroid profile. There are all sorts of new conditions which are present at an increased incidence after COVID. And that does include a wide range of autoimmune conditions. I don't know off the top of my head about autoimmune thyroiditis, but I would expect that it is present at a higher rate. There are some great papers investigating a cohort of many patients in the VA system, because the VA EMR is so integrated, and the studies there have shown almost feels like an almost universal increase to medical conditions, including autoimmune ones, in the period the several months after COVID. So thanks for your question.
Other questions? Anything else in the chat, Mary?
No.
I have a question, if I may, for Dr. Barada, regarding the COVID vaccine or getting the boosters. I can see some of folks with long COVID may be wary of the vaccine, and that it's the stimulation of the immune system might somehow exacerbate their symptoms, and especially with you saying that part of the theory is there might be some viral fragments that are causing the continued symptoms. That's kind of what a vaccine is a little, something
Sure.
that. So what is your position on a recommendation for people with long COVID, whether to get a COVID booster vaccine or not, or is there a?
Yeah, I definitely recommend staying up to date with vaccination, even for my patients with long COVID. Yes, so we'd just spoken a moment ago about the possible benefit of symptom reduction after vaccination. I've seen that in some patients, but not consistently. So we can't use it as a therapeutic approach, but to protect against future illness, including acute illness and the possibility of worsening long COVID symptoms, I think there is benefit for the vaccination. Unless the main time that I counsel patients against long COVID vaccination is if they had a prior substantial negative reaction. Some people who actually come to our clinic have vaccine injury from the COVID vaccine. So they get maybe dysautonomia or chronic fatigue that stemmed right after the COVID vaccine, apart from COVID illness. That's pretty uncommon for us, but it does happen. And I think it's certainly important to understand that there could be adverse reactions or side effects related to the vaccine, but the benefits of staying up to date with vaccination far outweigh the risk in my mind, including for people with long haul COVID.
Any other questions?
I have one more follow-up question. As far as the folks wanting to get better, feeling better, you had, in your slides, it said that for people with the post-exertional malaise, you do not recommend a graded exercise program. How do people then, if they're feeling better and they want, how do you know, when can you get better? How much can you do, versus shooting yourself in the foot and doing too much?
Yeah, it's a great question, and this is probably this could be a whole nother hour lecture, but I do have some pearls that I can share with you, and I can definitely offer some resources, maybe through Dr. Moore later. We counsel patients; they need to individualize. They need to have an individualized program. So they can't all have the same type of program, because for some it will be too aggressive. They need to stay physically and cognitively active as they're able to, but under the threshold that causes them to have a crash, essentially. So for some people, that might just be walking to the mailbox and back. That's all the physical activity they can do, because if they walk a couple of blocks, then they crash the next day. So this needs to be determined very carefully, and so we encourage a lot of symptom logging and activity tracking to find those associations. We're also frequently recommending wearable devices like a watch that will monitor the activity level, including the heart rate, because we're seeing that there can be some benefits from having a type of biofeedback in the moment and giving you some guidance. Oh, wow, my heart rate's spiking to 130, just doing this seemingly benign activity. I'm pushing myself too hard. And this is where an experienced therapist can provide benefit. But many times PTs or OTs don't know about this aspect to post-COVID fatigue and may push patients too hard. So if you do have patients going to therapy or trying to rehab themselves, you want to make sure that they know that they should not be worsening after their exercise. If they're feeling worse symptoms after exercise, and I'm talking substantially worse, like they can't get out of the bed, then they need to back down.
Okay, and Dr. Neal, if you want additional information, I can connect you with Dr. Barada, and he can, I'm sure, share some more stuff with you on that.
Thank you very much. Thank you, Dr. Barada, for that.
My
Dr.
pleasure.
Barada, there is a new question in the chat as well.
Yeah, so are there any studies showing association of long COVID with viral or particle load? And yes, there are. I don't know that it's necessarily a new study, but it's maybe a couple of years old now that shows that people with a higher viral load during the acute illness have a higher risk of developing long COVID. That was probably during study of maybe the Delta variant. So perhaps that's outdated, and I don't know how accurate it is still. But it makes sense to me. We see that people who are more severely ill from a symptom basis are also more likely to develop long COVID. So I think there is an association there, and perhaps that is why people who get an antiviral have a substantial reduction in the risk of long COVID development.
Any other questions for Dr. Barada? We need to probably move along pretty quickly here. Dr. Barada, I'm going to take the opportunity to ask you one more thing. Have you had much experience in the patients asking for or being placed on disability for long COVID? Is that an acceptable reason when you, as a doc, say they have it and tell them they shouldn't work, etc.?
Yes, I've done multiple documentations for those patients this week alone. It is something that I think I think it's incumbent on us as their providers to advocate for them in this way. It's tricky to do so when there is not clear objective evidence of like laboratory abnormality. But if you develop a comfort level with your patient, you understand their situation, and you feel like they're being genuine with the condition, then I would definitely encourage you to help them get the leave or the disability that they deserve. And there are resources online. I can share them with you as well on these types of disability applications for people with long COVID. It often gets denied, but on appeal, we can sometimes get them overturned.
And again, documentation serially is probably extremely important in that process.
Yeah, and I think documentation also of how their functioning is impaired. Social Security, the determination service doesn't really care that they're fatigued. They need you as the provider to link that fatigue to their inability to do functional activities. So they cannot stand as the cashier or whatever their job is because of their fatigue and muscle weakness. So you have to link the functioning problem with the symptom.
Well, this has been an outstanding session. Thank you so much. And Dr. Wolf, I know, is on the line. Dr. Brada, thank you so much.
Thank you, Dr. Wolf. Sorry to take so much time.
We love it with the discussion. If Dr. Wolf will go ahead and bring up his slides, I'm going to reintroduce him to our audience. He has
Dr. Moore,
been
can I interrupt you really quickly? I'm so sorry. We have two people attending, Tiffany and Gary. I just need a little bit more information. If you'd like an evaluation or credit, you can either drop that information in the chat, or you can email me at mary.kent@lifepoint.net. Thank you. Sorry.
Okay. Dr. Wolf has spoken to us as a group several times before, and we're delighted to have him back this evening. He is from the Duke Infectious Disease Group. His background is having grown up in Australia and having completed his undergraduate work at the University of Sydney and subsequently his medical degree from the University of Melbourne. A very interesting thing about Dr. Wolf is that his earlier degrees in his educational journey were in music and in performance piano. Yet he moved into medicine in his, if you will, in his later years, later being like late teenager years. So that followed him coming and doing his residency and registrar years at St. Vincent's Hospital in Melbourne and at the Monash Medical Center. He subsequently came to Duke, where he completed his infectious disease fellowship and has since that time been at Duke as an attending physician and a nationally and internationally recognized expert on vaccines and preventive infectious disease. He has well over 100 high-impact articles published and numerous book chapters. He's received numerous awards. He has a very unique experience of extraordinary medical engagement with the popular culture and with media, having been interviewed with a wide range of podcasts, newspapers, Washington Post, high-level information dissemination. Currently, he is a member of the NIH COVID-19 treatment guidelines panel for the nation, and he's currently the medical director at Duke of the Emerging Pathogens Unit, and he's heavily involved with managing of infections in organ transplant patients. This evening, he's going to be talking with us about annual vaccine updates, and I asked him to tack onto that a little blurb towards the end, let everyone know what's being recommended for monkeypox management. So, Dr. Wolf, thank you so much.
Thanks so much, Dr. Moore. I always appreciate the introduction. You're too kind. Can I just ask if you guys can see my screen? If someone can.
Yes, we can see it.
Yeah, terrific.
And we can hear you.
Thank you.
welcome.
And actually, my first thanks actually to John Barada as well. John, you've received many of our long COVID patients, and I've looked for your help as your clinic has been extraordinarily helpful to us over the last few years. So, a personal vote of thanks too. So hey, apologies. It always seems like the end of summer when we're just enjoying like still the last remnants of nice warm weather. Some guy like me comes along and tries to sort of bring us back to earth with impending winter vaccines. And so but that said, with these vaccines that we're going to talk about now are now in our pharmacies. They are being distributed as we speak to most of our hospitals. And so it's a timely opportunity, I think, to sort of walk through some updates. Unlike the last few years of COVID, where I really feel like we all sort of got beaten around with the sort of schizophrenic adjustments of how vaccines were being rolled out, I don't expect much of this to be too revolutionary, but hopefully just some little snippets. And as we said at the end, maybe some pieces of vaccine advice that we don't always necessarily think about. And just an adjustment to the intro, the COVID NIH guidelines that was mentioned there is now actually been shelved. That formally closed, and the website's now sort of finalized and mothballed as of about a month ago, which I think speaks to the fact that we've arrived at a point where this is chronic enough that we feel like the sort of introduction of further data is now slowed. So I'm going to start with influenza. Of all common things, you would think this shouldn't have adjusted too much, but there's some subtle information updates that I think are worth sort of talking through with all of your patients and family for that matter. So I always actually start, maybe because I grew up there, but also because of some epi reasons, with a reflection on what happens in the Southern Hemisphere, because I think it very accurately reflects what's likely to come to pass for us 6 months later. And I think if you look towards, this is Australian data, on the left, you look at sort of epi curves over the last 4 or 5 years, recognizing that COVID, of course, blurred this quite intensely. But the sort of, you're looking at two things. On the left, you're looking at presentations to health systems with fever and a cough, undifferentiated, not tested as to which virus we're talking about. And really the key point here is the green line, if you can see that on the color, is the most recent season. The dark solid line, a 5-year mean rolling average. The take-home message is that this has been a remarkably, quote unquote, normal season for them. The sort of initial phases coming out of the pandemic was that the seasons for winter viruses arrived not only early, but in ways that were quite staggered and not typical, I think, as we all sort of released ourselves from various levels of isolation. And really in the Southern Hemisphere, that has now normalized. So I think that's a reasonable reflection that we'll likely see the same. In people who've actually come to the attention of healthcare workers and been tested for influenza specifically, which is the graph on the right, you see a very similar message. So again, the green dotted line being a reflection of this winter's season for them, which they're coming out of, which is why the line is not complete. And again, getting some feedback from someone. Someone's on the telephone. The general sense is that this has been a relatively even-keeled season in terms of the magnitude, but also chronologically occurring at a pretty typical rate. So we translate that to us, we'd expect flu to increase in the latter half of December and probably continue through to at least February or sometimes as late as March. So where do we stand? The first thing is a real curiosity. I think I mentioned maybe to this group, it just arrived to our knowledge this time last year, was that actually a benefit of COVID is that it has led to the extinction of one of our flu B strains. So traditionally, we would always get 2 flu A's. We'd get an H1N1 and an H3, sorry, an H1 and an H3. And we'd always get one of 2 large families of flu B, either Yamagata or Victoria family. And actually, we have not seen one of those for now 3 years running. And the feel is in all countries that has largely been extinguished because of the travel restrictions that we put in place for a year. So the first thing you'll notice is actually all the flu vaccines now have gone back to being trivalent. That is not a reduction in protection. That is a reflection that we've only ever seen the remaining Victoria strains left in the B category. A sort of subtle benefit of COVID. However, we've sort of entrenched knowledge, which I think was really building probably pre-pandemic, which is that we now recognize that there's a tiering ability, if you will, between who should get what dose. And I don't think it should be new to this group that over 65 age adults are now recommended as standard for a high dose. That changed before last season, where it went from a suggested equivalent, you can consider this, if you will, to the ACIP going, hey, we actually recommend this. We think the data is strong enough to be supportive. It continues to be the case that they're agnostic as to which one, and there's actually data supporting both high dose vaccine, the typical, the one we call Fluzone, it's just literally 4 times the amount of antigen within the same injection. Adjuvanted or flu ad is the one for us, for example, at Duke that we stock simply by procurement costing advantages. It comes built with an adjuvant, which is obviously an immune stimulant and makes you more prone to be triggered by what you get in the injection. Or flu block, which is a non-egg derived vaccine for those with sort of high-grade egg allergy, is still actually quite effective. What's new is that we now actually have selective recommendations that actually in our highest risk under 65 patients. So in particular, this affects like my transplant patients, for example, there's actually a selective recommendation to include the high dose vaccines for younger adults. And the idea is the same. In the same way that we become immunosenescent as we get over 65, our immune system becomes forgetful or sluggish. Those who've been given chemo or transplant are the same. And so can I give you more vaccine stimulant upfront to be more protective? Question I always get all the time is like, when is the right time? Again, like we're just coming out of summer. Should I be giving someone a flu shot? This has always been tricky to me because I think you'll find compounding data going one way or the other. And my sense is that realistically, I try and recommend it to most people somewhere in October, recognizing that there's such a large number of people who we have to vaccinate that if we don't start in September, we're not going to finish everyone logistically. Lots of people we only see once every 3 months. Conversely, there is a durability question here that's at play. And I think particularly the older you are, the more at risk you are, typically the shorter the duration of your vaccine protection is. And so sort of October meets the right sweet spot, I think. Conversely, we start heading into November and December, we get a year like we had last year where flu arrived in November and we get caught without having vaccinated people. And at the end of the day, the final thing is if your 67-year-old comes to you and say, hey, doc, I just went and got the regular flu shot from CVS. Should I get another one? The right answer is the one that you've been able to get to that patient. So maybe a little pivot, quite intentionally, is, obviously this year has been some focus on a different form of influenza, and I think it's worth me just sort of giving you guys an update. Particularly as we may start seeing this creep into vaccine recommendations, although not this winter. So H5N1 is, as many of you know, an avian-derived influenza. The key sort of anxiety here, I guess, is if for those of you that think about influenza, we become very immunologically familiar with the hemagglutinin antigens that we've seen before. And so as a community, we've seen an enormous number of H1 and H3. We have not, for the most part, seen any H5. So this is not a virus that's surface proteins that we immunologically recognize. So the fear has always been similar to H7, similar to H2s, there's a whole variety of them, that if infected en masse, the community would have very little retained memory from previous exposure, in fact, arguably none, and therefore the proportion of people who would get quite sick would be high. So this obviously caught much attention recently, but it's worth knowing that, in fact, avian H5N1 has been circulating in the community of the globe for 20 years. This is new to the United States, and therefore it certainly catches people's attention on the front page of the New York Times, but it's not new to the globe, nor is it particularly new to North America in animal populations. This is sort of circulatory surveys that have been going on in the background quietly, sort of not on the front page of the newspapers, as done, for example, by the US Geological Survey, showing really widespread bird migratory patterns typically as the lead trigger. This is poultry, but similarly, if you look, you find it, in fact, in this extends to a multitude of different animals, depending on the different colors. And so I really include this as more of a sort of a wake-up call to us. This has been an illness that so far has been really devastating to a lot of native animal populations, not only in the United States, but sort of up and down the American coast. There's been sort of large seal populations wiped out in Chile. It's reached Antarctica. There's been really no continent unaffected. Knock on wood, the human infections, which I now show you, have been mild. So on the left, you see the states with human infections, and this is an old slide as of last week. It should include Missouri. On the right, you see cattle farms that have been involved. This is super likely to be a gross underestimate for a number of reasons. If you're a dairy farmer in Virginia or in North Carolina, you don't particularly want to be identified by the state health department or Department of Ag as having a bird flu outbreak. So there is sort of affirmative disincentive to test in the right way. And similarly, if you look at, if you're a large cattle farm in southern Texas, it's probably incumbent upon many of your workers to not want to come to the attention of public health either, for lots of reasons, which I'm sure you're aware of. So this is likely an underestimate, but what we do see, at least so far, is that cases, knock on wood, have been mild. All bar the case in Missouri have been clearly documented links with human and animal interface. So we don't think yet that this is transmitting between people, and there's not been any severity at this stage. So watch this space. I think, as influenza has traveled across the world and typically evolved, we have seen it acquire the capacity to move between mammals, which this has not yet done, at least in terms of humans. The issue unique to North Carolina and Virginia is, in fact, that we have a lot of hog farms, and pigs are unique for these influenza strains because they can accommodate multiple influenza strains at the same time, therefore allowing assortment in a way that can encourage transmission cycles. So watch this space. We have vaccines. Actually, our Duke Vaccine Institute is working on production of one as we speak. It's not going to be in the arms of people, hopefully, anytime soon. So a little bit of background epi as a final thing. People may be familiar with these sorts of graphs. These are typical flu season graphs where we survey what comes into laboratories all across the country. This is for our region. This is region 4. And you can typically see that we see flu A and flu B. A is the predominant. What we do notice is that we shouldn't be seeing any influenza right now. And so you combine that with a benefit out of the COVID pandemic, which is actually the establishment of a lot of wastewater sites where we assess human effluent and animal effluent and get to detect viruses. And so sometimes what we do is we see spikes in local influenza A cases in areas where we shouldn't at the time of the year, and associate it with H5 being found in the sewage, and can sort of make the link that way to say, aha, there might be a farm outbreak in that place. So let's move on briefly to COVID and my drink break real quick. Promise this will be brief, and in fact my biggest take-home point was beautifully summarized by the previous speaker, which is to say there still is a benefit in terms of widespread vaccine, both in terms of long COVID prevention, and I would certainly endorse the same anecdote of a number of people improving their long COVID symptoms after vaccine, but simply ongoing transmission cycle breaking. So those wastewater test sites that we talked about before that continue their surveillance role have seen a very classic late summer increase in COVID numbers. And so, typical of what we've seen for really every July and August so far, we're seeing the same thing again here. So transmission is certainly proving viable, and I think it's certainly also coming to our understanding that this is going to be a twice annually, I guess, illness. Initially we thought maybe this was just a winter phenomena. It was hard for the first few years to really understand the periodicity here because we would continue to get different variants every season. The last 2 seasons, which have really been Omicron only, have had spikes in that sort of July, August period, really without major modification of variants. So I think this is a real twice annual frequency that we're now falling into. and should be aware of, particularly for our at-risk people. What it has not translated to, though, is a substantial increase in hospitalizations, thankfully. So the red line here represents US hospitalizations. You can see it's certainly gone up compared to where we were in April and May, but nothing compared to the blue or green lines that represented sort of 2021 and 2022, and that enormous spike in January when Omicron sort of washed through everywhere. So busy, but community-centric, not fortunately hospital-centric at this stage. So what does that mean in terms of vaccines? Well, we're now in this sort of nice place where all those previous confusing recommendations about who could get 2 doses and 1 and how many months and who needs what when, they're just all gone. The easy recommendation is this has now fallen in line with influenza vaccines, that we should all be lining up, particularly as healthcare workers, in front of patients and those who are high risk for an annual vaccine. We do say 6 monthly for people who are immunosuppressed enough that we don't expect them to mount a response. So for me, that's all of my fresh leukemics, my reasonably recent solid organ transplant patients, anyone, for example, on rituximab or other drugs where you think they're not going to respond. Just within the last 2-3 weeks, the FDA has reissued EUA approval for the 3 main vaccines. Like you would be aware, Pfizer and Moderna mRNA platforms, they are now starting to see a slight differentiation this year between themselves and the Novavax vaccine in terms of the strain that they include. And I think this is a reflection of the speed at which mRNA vaccines can now be manufactured. They don't need the length of lag time to get the seed vaccine strain into the development. So they represent a vaccine against KP2, which is an Omicron subtype, Novavax JN1, a slightly older one. Probably this is not going to translate to a huge defensive difference, but it's been enough for us to say, look, preferentially we would still prefer Moderna or Pfizer. It doesn't matter which one. Dr. Barada earlier had mentioned that occasionally they do still see, and we certainly have too, patients with really significant inflammatory or sort of dysautonomic responses due to vaccine. We have comfortably vaccinated, as best I can recall, anyone who wanted to in that situation. If they got it with an mRNA platform, we would vaccinate them with a Novavax vaccine. And different antigen, different means of stimulating the immune system, and they've tolerated that fine. I wouldn't use that as a blanket statement. I think, there've been a couple of people who we've needed to go up the channel to the ACIP and some of our vaccine consultants to really sort of ask, but it can be a useful alternative, I think, the Novavax shot for folks who want protection, maybe at high risk, but had a severe reaction the first go around. If your patients like mine are increasingly skeptical about, like, hang on, why am I getting so many shots when COVID doesn't seem to be, shutting all the restaurants like it used to be? I think these are useful statistics. These are all available with the studies that are on them on the CDC guidance page. For me, the biggest one that makes a difference is actually to compare this against flu shots. And I think, people are happy enough with their annual flu shots that the comparison is real. And I would say to them, a good season for a flu vaccine, we would match about 35 to 40, 45 maybe percentage vaccine efficacy. That's if I had 100 people who are going to get flu, 40% of them don't as a result of vaccination. That compares to a better response rate with COVID. And typically we would I tell people we expect to cut out, based on previous variants, about 50% of the illnesses. And that's a meaningful number. I think, if you're an immunocompetent young adult, you can still sort of sell that to patients to say, look, hey, if you've got an important event coming up, if you've got key travel, if you've got if you've got a high risk person who lives in the house, reducing your risk of transmission or your risk of being sick and interrupting lifestyle issues by 50% is reasonable. It's clearly a bigger issue still for the immunocompromised or nursing home residents in that same breath. And you can see there about a third reduction for them in terms of risk of severe outcomes. Again, very reasonable when it comes compared to other vaccines that we now take for granted. There has been a lot of work in actually trying to combine flu and COVID. We do have lots of data to support, and I'm happy to share it if people need, with the co-administration of both being safe and equally responsive to both. we had hoped that by this season we'd be in a position where in fact they'd be co-formulated. Moderna, for example, is trying hard to do that, but they have not yet come through their phase 3 trials to make that work. Hopefully next season, which would be great, saves us all the logistics of giving an extra vaccine. Pivoting slightly, it's not really a vaccine, but in the idea of generating defensive antibodies, it is worth remembering that there at the moment is a single monoclonal preventative antibody still available. It's called pemivibart. This is the same as Evusheld used to be, for those of you who are more familiar with that a couple of years ago. A little bit different. We don't have as many people with severe COVID these days. And so the question being, who would want to line up for an IVIG sort of IV infusion as a defense against something if they're not going to get particularly sick? What's clearly relevant here is that this is appropriate for people who do not have good humoral response. They don't make good antibodies. So patients on rituximab, patients with CLL who are hypogammaglobulinemic, some of our fresh lung transplants, for example, lupus patients who might be on rituximab and also have lung conditions. So you can think of the most extremely high-risk individuals. I do think this is useful. You can see in the red that I've highlighted the results of their recently presented study, which took high-risk individuals and simply said placebo or the infusion, and you can see an 85%, 84% protective efficacy. So for the people who don't make their own antibodies, or you really think they make them poorly, this is something really to consider. The red flag, and I think the logistic reason why it probably hasn't taken off as much as it might have, is that they got a black box warning for anaphylaxis. And so to me, this is a clear indication to be very selective about who, if anyone, you want to give it to. The black box would say 4 out of 623. When you look into the weeds of who exactly those 4 were, I think it's probably half of those people actually getting a reaction, so maybe 0.3, but it's not 0. And so, 0.3% risk of a serious reaction is enough that we give this only in our infusion center. It's only approved by ID and ID pharmacy. It needs a secondary level of approval from their insurance. But I do think for those people who are listed at the top are super high risk, this is still a relevant issue. And happy to talk more if need be. So let's pivot a little bit more. So, RSV we typically think of in kids. I think the community sort of visibility of RSV is of that critical illness for young neonates, but of course it actually affects adults. And classically affects adults in ways that I don't think we really appreciate. So this is sort of estimated numbers of hospitalizations in the United States. This is all pre-COVID data, mind you, but there's no reason for it to be different at this stage. And you can really see that jump in the age range greater than 75, where an annual RSV associated hospitalization of sort of 200 to 300 per 100,000 is a meaningful number. And so this, who are these people? These are the people who are coming in to your ED, into your hospital with exacerbations of COPD that in the past we just may not have been able to put a name to because we didn't typically run RSV tests, or at least they weren't very sensitive compared to our current molecular platforms. Now that we see those tests, in fact, we are identifying more RSV. It's not that it's suddenly increasing, it's just that we now can see it. So with that, the question is, well, what do we do about that? And I think there's a few things here that are key to sort of tease out. The first is, again, coming out of COVID, epidemiologically, this presented differently. You can see the dark solid black line was 2 winters ago when RSV actually arrived really early. It now, according to the Southern Hemisphere and what we saw last year, is back to being a winter virus from sort of December to February. We have 3 vaccine options now. Moderna was also just approved. They've got an mRNA vaccine similar to their COVID. They are very similar in efficacy, and it's not reasonable for me to recommend one over the other, with a couple of exceptions. So number one, unlike last year where ACIP sort of said you should consider this for anyone over the age of 60, they've sort of demarcated that a little bit more, and they've said, we think that incidence of hospitalization, so severe lower tract RSV in over 75s is high enough, and having rolled these vaccines out for a year, a previous concern about neurologic symptoms, so Guillain-Barré, acute demyelinating encephalomyelopathy, which was seen in a couple of the trials in very, very low numbers, like 1 or 2 per trial, did not represent themselves in phase 4 trials. And so we now recommend this to people over 75, and we suggest a discussion for people 60 to 75. And so I think you can take older adults much more forcefully into a conversation and say, look, hey, this is really protective. It is not a virus that mutates as fast as flu or COVID. So the need to have it as an annualized vaccine is not there. And in fact, it's held up better over multi-seasons. We think it'll probably be 2 or 3 years between doses. There's an approval for folks between 50 and 60 for the GSK dose. I'll talk about pregnancy in a little minute. Both of these were published in the New England Journal last year, so it's easy to go and look them up. I can share the links if folks want. But the take-home point is that the efficacy in blue on the left was basically the same, and I don't think people should pass into a difference between the 2 vaccines necessarily. And the Moderna trial, which came 6 months later, was largely the same. What you can see in the bottom slides in the middle and on the right-hand side is that it's quite side effect notable. You know, I would put this on a par with, say, a tetanus shot or Shingrix in that it's very stimulatory. People will describe a good sore shoulder for a day or so. We get you can see there a third of patients getting fatigue. So it's quite stimulatory. I tell people to get it on the Friday before they have the weekend off. But that's, at the end of the day, protective. When we've looked at it in that 50 to 60 age bracket, very similar side effects. So again, you can have a conversation with, say, severely emphysematous 53-year-old now to say, hey, I think you should really think about an RSV shot as a protective means. So the new cab on the rank was Moderna. They were just 6 months behind in their trial, so marginally different vaccine efficacy there. You can see in the bottom sort of around 80% protection for lower respiratory tract RSV. So, you know, we don't expect this to be measured in a way that, you know, does it stop rhinitis? The question that's important clinically is, does it prevent you getting lower respiratory tract disease and ending up in the hospital? Unlike the other 2 vaccines, they had no cases of Guillain-Barré or ADEM, so maybe this is the vaccine for someone who you're a little bit more nervous about their reactogenicity for. What you can see on the right is sort of 2-year data. So unlike flu shots, which sort of fall into the 10 to 15% after a year, this is still sort of maintaining around 40 to 50% protective efficacy. So again, that idea of not needing it annually. Kids, so, you know, we say neonates are the most severely affected. Well, the idea now is held that we should vaccinate their mums and a maternal transfer. And so the key here is that this trial with Pfizer only, it's the only one approved in this setting, took mothers in their 3rd trimester where the expected delivery date was in the middle of RSV season. So if we're seeing mums entering their 3rd trimester now, in fact, that's the right sort of group of patients to look towards. And the idea is, can I get a 2-for-1? Can I protect mum and protect the newborn? And you can see at the bottom an 80% reduction in RSV healthcare associated visits for the child. Now that's a really meaningful endpoint. And I think this is making more of a splash in our OB-GYN populations. I haven't included here the alternative, which is that we treat high-risk infants at the seasonal right time with an antibody for them. There is a product called Nirsevimab, which allows that to be done if you miss the giving of a vaccine to mum in her 3rd trimester. But this was safe and a good strategy. So this is kind of the summary. If you want one page to like print and stick on your wall, you know, this is the one. Realistically, for folks over the age of 75, we're now talking clearly about 3 vaccines. You know, a high-dose flu shot, a seasonal COVID boost, preferably Moderna or Pfizer, and an RSV vaccine if they didn't have it last year. High-risk adults younger than 75, you may still also be recommending 3, but it's a little seasonal and dependent on where they stand. Are there gaps in our knowledge here still after all this? And I think there are. I mean, I think what we've seen is we've shown that for someone who's high risk, giving more antigen or more stimulation is more protective. Well, the question is how much more? And so we've actually got a couple of trials moving forward at the moment, run through the NIH, for example, in our transplant population, to say we learned in COVID that the idea of giving one vaccine was effective, but giving it in a prime and then boosting them a month later strategy was more protective. Can we think about that differently? And so actually there's a lot of trials ongoing at the moment to say, hey, maybe a high dose vaccine is not enough for someone who's truly high risk. Can we kind of double their dose in an incremental way? Not useful for most people, but if you're a lung transplant recipient at high risk of a bad outcome, this is super relevant. Watch this space. So I'm going to pivot for the last few minutes, and I'm conscious of time. I want to talk about two extra things. The first, I think we all forget about whooping cough. We have seen a few cases lately, and certainly at Duke, we've seen a few. Nothing on the graph compared to what we saw in the 40s and 50s when this was just ubiquitous. The introduction of vaccines for whooping cough was just revolutionary, but we've just seen increment increases in the last 4, 5, 6, 10 years. It's a once every 10-year vaccine to give someone tetanus. And I don't really care about tetanus, but I do care about whooping cough. And so I routinely now preferentially give everyone a Tdap as opposed to a TD, which I don't understand why we still market TD, to be totally frank. The only logistic headache is that you guys like us are not allowed to give in our clinics, at least in the hospital setting, tetanus or Shingrix or the RSV vaccine for folks who are Medicare eligible. We don't get paid for it. So this is a recommendation for an older adult to go to the local pharmacy or primary care and get it there. But it is worthwhile thinking through. There has to be adult cases of pertussis to continue cases occurring in kids. The kids don't traditionally just pass them to themselves. There has to be an adult part of the feed there that we just keep clinically missing. So this is helpful. The second one is Mpox. Dr. Moore asked me to comment on this. Last year I was hopeful this was sort of a 1 year and done event, but it's clearly not true. So the US has continued to sort of see about 60 to 80 cases a month. Nothing compared to the thousands that we saw in the summer of 2022, but it still exists. It is almost universally in the United States a male issue for men who have male sexual partners, or at least are in the sexual networks. We have a vaccine that's very effective. So we knew well before Mpox came about that studying of the Genios vaccine was designed for smallpox, but highly effective against this closely related virus. It's 2 doses a month apart, can be given to immunosuppressed patients. It's a attenuated non-living virus. It's certainly probably available, I suspect, in your hospital, but certainly is available through your health department. Why it's hit the news again, and as a reminder, this is a blistering rash that predominantly occurs on the skin, causing painful sort of varicella-like pustules, which exist over a couple of weeks, but can be internal and ophthalmic, and certainly can occur like herpes at the site of penetration. So for lots of men, this presented in horrific proctitis, sort of to the point where we would see some people with sort of pseudo bowel obstructions because it was just so exquisitely painful for them around the rectal anal margin. What we see, what's brought it to attention is that there's another outbreak happening at the moment, unfortunately, in Central Africa. So there's 2 clades, two variants, if you will, of COVID, of Mpox, sorry. We ran into clade 2 in the United States a couple of years ago. The current outbreak is clade 1. And why that's important is that clade 1 had traditionally been isolated purely to the Congo, parts of Cameroon, Central Africa, had a statistically much higher mortality and dissemination rate. What has occurred as that has now started spreading throughout parts of Central Africa as far as South Africa is that we've seen it evolve. Not surprisingly, this is a virus. It wants to do that. Evolve in a way that has sort of led it to be called a separate clade. It's now 1B. And it is passing not only in male-to-male sexual encounters, but it is passing in, it seems to be at least more readily in close contact. There are kids passing to kids. There are adults to adults within households in ways that we didn't really see in the North American outbreak of 2 years ago. How much this really extends, how much this turns out to be sort of a more potentially lethal substrain of Mpox compared to what we saw 2 years ago is unclear to me, frankly. But it was enough for the WHO to call it an emergency declaration last month. What it actually means for our patients, I think, is this has sort of redoubled my conversation, frankly, with men who have male sexual partners to say, look, we've got a safe vaccine here. It's 2 doses. It is lifelong protection. Why the heck would you not go ahead and get it? And there's no seasonality to it. So right now, priority flu, COVID, RSV. But if you're a sexually active guy, or particularly you're someone who heterosexual or bisexual, it doesn't really matter. If you've had recent STDs, I would include you in an at-risk group who should also be Mpox vaccinated. This is an awfully painful condition for those who get it, and you can protect against it. So final slide is, should we prioritize certain ones over the other? And, there's now good data actually to support flu and COVID together. Like I said, hopefully by next year, they'll be in the one vaccine. We have reasonable data that RSV and COVID together is okay. The CDC would officially say you can give all 3 together if you're so inclined and you think the patient's never going to be seen again in a clinical space. Just do what you can. My personal preference is that I typically give flu and COVID together at the same time. I would wait and give RSV and Tdap usually later, only because I usually have to refer them out to a peripheral clinic. If they're 60 to 64, you can do it in your own space in the hospital and get it done that way. And again, Mpox isn't seasonal, so it really can be any time you can get the patient to present. Same with whooping cough. So I'm going to pause there. I know this is running a little bit short on time. I have not had a view of the questions over the time of my talking, so I'm happy to take some or whatever you want to take from this. But yeah, hopefully that was helpful.
Wolf, do we have questions for Dr. Wolf? Your time is fine. Dr. Pradhan has just popped up, one of our local internists. Dr. Pradhan, do you have a question or comment, my good friend?
Quick question, 2-part. One, the current flu vaccine, both are 0.5 ml, regular dose and high dose. Is it different in antigen amount? That's one question. Second question is, can you comment on PCV21?
Yeah. So you're right. So the high dose, if you're using the one termed flu zone high dose, is just 4 times the amount of antigen within the same dose. So it's the same mil volume, but there is more antigen contained inside. So it's you could give 4 regular jabs or 1 high dose, and it's exactly the same antigen load. So that's all the difference is there. I didn't go into pneumococcal. I guess partly because there's a sort of a pending battle, I think, between companies who manufacture pneumonia vaccines, with Prevnar and Pneumovax both sort of increasing their strain count, for want of a better phrase. PCV20, I guess, I think is what you would mean. And I would sort of now supplant that really with for anyone who's had one of the vaccines. I now just replace them with a PCV20 and call it done. I think it's actually simplified things for the most part, is that you can do a one and done strategy there. Whereas in the past, we sort of had this sort of, Pneumovax every 5-year strategy. It's not usually as required. It's a different issue for someone who's an older at-risk adult who has not yet had any pneumococcal vaccine. And I think in that situation, we still have the same theory of giving 1 Prevnar and 1 pneumococcal 23 with the 8 weeks apart, because they do work in a slightly immunostimulatorily different way. So really, to me, it's just a replacement for 13. I don't view it as any different in that regard.
Well, the data which is available now, talking about conjugate vaccine 21, suppose it could be better than the 20, and that creates a confusion in a year or two when it comes out. The same struggle we have now. If somebody has had the conjugate vaccine 20, should we give them 21? And then we struggle. And you're right, 13, 15, 23, and that's all confusing. So it was so simple, easy, because one time you were done and be done with. So Thank you.
I mean, honestly, it is that confusion that leads me to speak to most people and say, look, just give them a 20 and at the moment you're okay, and prioritize other things. Because let's be, I don't know about your patient population, but if it's mine, I get about 10% of people who actually wait and get every single vaccine that I talk to them about. And the majority go like, you prioritize the one that I'm going to get, doc, and that's all I'm going to stick around for. And then you'll see me in a year. So I don't know. I prioritize PCV 20 because it seems easy and reactogenic enough that I think I'm getting good defense from it.
Thank you.
Gary, did you have a question? Your hand's raised, or it was? Okay, Dr. Shaw has a question in the chat. If you can you see that, Dr. Wolf? Said it's a hard time for insurance to approve Tdap unless they have an injury. Is this true, or am I putting in the wrong code?
That's a great question. I've not run into that problem, but I must say I don't usually get the patient coming back to me on the back end. So I might be missing some people who are getting unusual bills in that regard. I usually put it in not as a needs tetanus, but I usually put it in as a needs vaccination and sometimes I think there is a code actually specifically for needs whooping cough or need pertussis. That may be your way around that. I don't claim them as injurious. And to be fair, I don't know what CVS is charging if I send them to CVS or how they're billing it. But that I've never had a patient come back and say that they got an egregious bill that way. But I should look into that and get back to you. It's a great question, and I'm not sure I answered it perfectly.
Other questions or comments from anyone?
I guess my retort to that in some ways would be, if you're still getting that, I presume you're getting that warning if you are trying to give them a tetanus boost in general outside of an injury as well, whether or not the pertussis part of it is in there. So I should look in and see if actually giving the Tdap and sort of billing it through a pertussis algorithm, in fact, might help. I'll try and answer that for you offline.
Well, the cost of the Tdap, the Medicare allows $70. A good RX gives you for $59. And but then if you code for the regular need for immunization, they will not pay. Medicare covers on Part D, because most of the office we don't have Part D, so it doesn't cover that. So I direct to the CVS pharmacy or any of the pharmacy. So
yeah, I think that's the same issue for us, is that once you get to Medicare, we can't remunerate, so we direct them outside. Same with Shingrix, same with RSV, frustratingly. Because half of the people say yes sir, no sir, and then just drive straight home. So as I've frankly done as a patient too.
Any other questions, comments, concerns? Okay, well, Dr. Wolf, we thank you as always. We have typically had you come about once a year and share what we should be doing for adult immunization updates. And as always, you did a great job this evening. Mary and I want to thank everyone that's on the call this evening. We had a really high turnout rate, 90 folks, which is up at our higher levels ever. And that makes us feel good that we're meeting a real educational need. So thank you for being with us. I hope you'll choose to come back in 2 weeks when we talk about women's cardiovascular health, and particularly the challenges of diagnosing coronary heart disease in women. So thank you for being with us. Please be careful out there. And we wish everyone a very good night. Thanks a bunch. Bye-bye.
Thanks, Mom.
Thanks, Dr. Wolf.